We discuss now a very important talk. This concerns the familial Mediterranean fever, which is known as FMF or in Arabic حمى البحر الأبيض المتوسط. Why it is حمى البحر الأبيض المتوسط? Let me to discuss this with you. First, in New York, allergists first described the attack of peritonitis in 1945, and in 1972, colchicine was discovered to prevent these attacks. FMF was known to be familial within families of Mediterranean Sea. This is the Mediterranean Sea, and this is the countries Greece, Turkey, Syria, Morocco, and Italy, and Algeria. But the most common countries affected by FMF: Jews, Arabs, Turkish, and Armenian. FMF may occur and may be found in areas away from Mediterranean and may affect any group in unexpected locations, including Europe, USA, Japan. Familial Mediterranean fever is an inflammatory disorder that causes recurrent painful inflammation of the abdomen, lungs, or joints, usually with accompanying recurrent fever. If FMF was known to be familial. Why it is familial? And that is why we say familial Mediterranean fever, familial in families, Mediterranean in the Mediterranean area, fever, because there is always fever with the patients. FMF, familial Mediterranean fever, was known to be familial. There is a link of familial Mediterranean fever to gene. The gene was discovered in 1997, passed from parents to children. FMF caused by a gene mutation, 2 mutations for clinical disease. The effect of environment for clinical manifestation. This is a family. This is mother, unaffected carrier mother, father, unaffected carrier father. What for children? One not affected, both two unaffected carrier children, and the fourth affected child. Therefore, gene mutation cause an abnormally non-functioning brain. Brain is important. This non-functional brain leading to prolonged inflammation, the most common mutation at gene 694. What is the brain? Brain fighting infection. Brain direct the white blood cells to the sites of inflammation to stop it. or slow the inflammation. Gene mutation cause non-functioning pyrene, therefore there is no stop of inflammation, there is no slow of inflammation, there is prolongation of inflammation. As we see here, this is pyrene, normally get rid of direct the white blood corpuscles to the site of inflammation, but when it is not functioning, therefore there is no direction of white blood corpuscles, there is delay or slowing or stopping the cannot stop the inflammation. Therefore, the inflammatory episodes, it is not only inflammation, but it causes excess production of amyloid. When there is excess production of amyloid, there is deposition in kidneys. Therefore, FMF with a gene mutation 694 associated with an increased risk of amyloidosis. As we see here, this is the amyloid kidney. Therefore, family history of the disease of Mediterranean descent, the exact mechanism triggering the acute attack is unclear. The attack may occur suddenly without detection that it is coming. The cause is not clear, but it is suggested that vigorous exercise, exposure to cold, emotional stress, fatigue, menstruation may trigger the attacks. From my experience, I am sure that emotional stress, I am sure that the menstruation may be a triggering cause. But the attack may not occur during the second half of pregnancy. It is due to the hormonal changes. Therefore, FMF more in men than women from 50 to 60 are younger than 10 years. From 80 to 95 are younger than 20 years. From 1 to 10 are older than 20 years. Therefore, the first question I ask my patient, when the first attack, and I want to know when the first attack for a long time, since childhood or since adolescent, therefore I can catch the diagnosis. But it is not common in person older than 40, but it occurs. I noticed some patients more than 40 years got the attacks of FMF. Therefore, the symptoms usually before 18 years in 90%. The classic onset of MFF without warning. Some have alarming symptoms. Say the attack coming. The paroxysm develop over 2 to 4 hours, and it is severe and lasts 2 to 4 days, and the peak within the first 12 hours. But the analgesics and antipyretic may make the temperature not present, but temperature rises rapidly 38 to 40. But we got analgesic or antipyretic, you cannot notice this fever. Resolution occurring more slowly after 3-4 days the patient completely free. Nothing happened. Therefore, there are 7 types of FMF. The classic FMF attack, which is the abdominal pain and tenderness, may be focal and progressive to become generalized the whole abdomen, the patient walking, bending, supporting his abdominal wall for any movement may be painful, with all signs of peritonitis. The, the patient don't let you to put his hands for examination. There is guarding, there is tenderness and rebound in 95% of patients, may be like appendicitis or cholecystitis. Therefore, in 1970 and 75, FMF not known to all physicians. Therefore, we find at that time many patients of MF got appendicitis and appendectomy, and others got also cholecystectomy without any inflammation, because this abdominal pain look like the surgical peritonitis and always open to search what is the cause of peritonitis. But now it is well known to all patients, even it is overdiagnosed and not misdiagnosed except in rare cases. During the attack, there is constipation. When the attack finishes, therefore diarrhea after the attack. This is a picture. He support his abdominal wall. Cannot not let it to move because the movement is painful. Bending down to make a room for the inflamed peritoneum and walking slowly because any movement painful in the abdomen. The next attack in other persons may be in the big joints, mainly in the large joint. Therefore, the attack may be in the chest, pleuritis, may be pericarditis. Therefore, pleuritis occur in 40% of patients. The patient cannot take a deep breath, it catches the breath. Scrotal attacks, I didn't find the scrotal attacks. Pelvic inflammation in female, myalgia, muscular tenderness, lasts 3 to 6 weeks. Bouts of fibromyalgia last as long as 1 month and sometimes involve the abdominal muscle, and this is always notice these patients and suspect it is common cold or influenza. Erythematous rash in 15 to 50 centimeter below the knee joints and may be accompanied by swelling. Fever without any other symptoms in 25%. Therefore, this is the erythematous like erythema, raised erythematous rash, most common on the dorsum of the foot, and this is raised erythematous rash in the lower leg. Symptoms, and these symptoms mainly fever, peritonitis with tenderness, rebound, guarding, arthritis as we see, pleuritis, catch the breath, erythematous like erythema as we see. Here, it changes with the location, Turkish, Jewish, Arabic, Armenian, Japan. Arabic. In Egypt, fever and peritonitis. This is our common symptoms. And fever sometimes not noticed because of analgesic and antibiotic. Arthritis may be, pleuritis may be, especially in the family of a patients of FMF. Therefore, the plant. This is the disease and this is the treatment. And this is the treatment. Therefore, two types of FMF. FMF associated with amyloidosis. FMF recurrent attacks with amyloid production with every attack. Therefore, what we are fearing from FMF, not only the fever, the pain, the arthritis, but also the result of these attacks, which is amyloidosis which affect the kidney, proteinuria, and end-stage renal disease. Therefore, we should diagnose FMF. What is the diagnosis? Clinical feature is very essential. Please hear very well to your patient. Be silent to know everything. Don't move from your place. Don't examine your patients except you know exactly what the problem. If you don't hear well, you miss the diagnosis. Therefore, clinical examination and exclusion of other diseases. Therefore, don't rush. Don't overdiagnose. Therefore, recurrent abdominal pain, chest pain, joint pain, fever may be due to other diseases. Therefore, the hearing well, examine well is the proper diagnosis of FMF, and actually it is better than the investigations. What is the investigations? We find leukocyte count is high with neutrophils, sedimentation rate is high, CRP is high. Therefore, these elevated levels rapidly return to reference range as the attack ends. Take care of amyloid A protein. Take care of the urine examination for proteinuria. This is the first step for amyloidosis. Don't miss imaging of the peritoneum, pleurisy, and arthritis. Sometimes we need histological examination for massive amyloid infiltration in the rectal mucosa, just rectal snip and examine, and may need a renal biopsy. This is the rectal snip and is stained by concurrent stain and positive for amyloidosis, and this is from renal biopsy, and we find the deposition of the amyloid material in the glomeruli. Therefore, may need genetic testing because as I said before, the gene 694 is very important. The mutation of gene 694, it is the cause of amyloidosis. Therefore, genetic testing in atypical cases of FMF for the common mutations, there are 17 mutations in FMF, but 80% of MF mutations are located in these 694, 726, 680. This is the mutation in these genes has a significance. Others, it is not significant like these genes. How to get this? This is by examination. We find these genes 694, 694, 68, and so on. Therefore, you can detect what is the gene and what is the mutation in the gene. Therefore, homozygous 694 mutation at risk of amyloidosis. Therefore, take care. When you are 694 mutation, the possibility of amyloidosis is coming. Close follow-up and treatment. Therefore, the treatment is very important even if cannot stop the attacks, but it can prevent the development of amyloidosis. Patients with two mutations have risk for amyloidosis, close follow-up and treatment. Therefore, the complications of MFF, amyloid production in a large quantities during attacks at a low rate in between. Therefore, recurrent of attacks, every attack, there is amyloid production. When there is amyloid production, a renal involvement is the predominant feature. It begins insidiously, causing proteinuria, thicker of urine. The first step is protein in the urine. Then progresses to symptomatic nephrotic syndrome and ends in the renal failure after 2 to 13 years from the onset of proteinuria. Therefore, take care to examine the urine for proteinuria. It is the first step for affection of the kidney. This is amyloid kidney. Therefore, may have malabsorption due to intestinal amyloidosis, may got adhesions of a small bowel, but obstruction rare, may got hypertension in 35% due to renal vein thrombosis. And this is very important problem. Infertility. Infertility. And there is many women with infertility due to FMF. Infertility in women due to inflammation may affect the female reproductive organs, causing infertility, also peritoneal adhesions. We may get spondyloarthropathy, prolonged arthritis of certain joints, and protracted myalgia. Therefore, this is a case of adhesions of the small bowel but without obstruction. Therefore, it is very important to know the management. The management is very important and it may lifelong treatment. Therefore, before you start, it is very important. The diagnosis is very important. History, and I told you now, don't put your hand on your patients except when you know the disease. If you examine your patients and you not know the disease, you cannot catch the disease. History including family history examination to assess the problem, serum amyloid at the initial diagnosis, urine for protein including 24 hours, urinary protein and renal function tests, rectal biopsy for presence of amyloidosis. Therefore, the aim of treatment of FMF is prevention of recurrent attacks and this is one problem. But the most important problem, the prevention of the development and progression of amyloidosis. And this is very important aim for diagnosis, for treatment, even the treatment not prevent the attacks. Therefore, the treatment prevent development of amyloidosis even in the presence of the attacks. Therefore, what is the indications for treatment homozygous or more than one heterozygous mutation for genes 694, 680, 694 are strong evidence of having severe disease and at risk of development of amyloidosis. Treatment should be considered with colchicine and close follow-up, not enough treatment. Follow-up is essential. Patients with one mutation, diagnosis suspected but not proven unless features of FMF are present. Therefore, the clinical presentation is very important for the diagnosis. Relief of symptoms with colchicine for 6 months and recurrence after cessation. The third, patients who have only mildly infrequent inflammatory attacks, either treated with colchicine or better monitored every 6 months for the presence of proteinuria. The last, treatment less indicated for homozygous or heterozygous mutation 148. This is not important gene mutation. Colchicine given if they develop severe inflammatory episodes or proteinuria or amyloidosis. The treatment, the only treatment for a long time and will be for a long time in the future is colchicine. Colchicine. Crocosis, which is colchicum plants, the source of colchicine. This plant, and I see you before. This is colchicine. Colchicum was the treatment of rheumatism in an Egyptian medical papyrus 1050 BC. Colchicum was first described as treatment of gout in the 1st century. Colchicum plants were brought to North America by Benjamin Franklin, who suffered from gout himself. Oral colchicine have been used for many years as an approved drug. Therefore, in July 30, 209, the FDA approved colchicine as the monotherapy for the treatment of familial Mediterranean fever and till now, and will be the only treatment for familial Mediterranean fever. Also, for the treatment of acute gout flares and prophylactic from flares. FDA allow URAL Pharma marketing exclusively for 3 years. No other pharma will make this treatment except URL Pharma. Therefore, colchicine orally 1 to 2 mg per day in adults. Colchicine 1 mg per day prevents renal amyloidosis even if FMF attacks do not respond to drug. Patients should receive colchicine for life. For life. Children may need half to 1 milligram per day. Response consists of reduction in the frequency, severity, durations of the attack. Within 6 months, therefore, the attack don't occur. Long-term therapy highly effective and quite safe with only mild and infrequent side effects. Here's the complications of colchicine. Common side effects of colchicine: bloating, abdominal cramps, lactose intolerance, and diarrhea. They can be minimized by starting at a low dose and gradually advancing as tolerated. Splitting the dose, use of simethicone for flatulence, and avoidance of dairy products. Complications of colchicine occasionally include myopathy with elevation of creatinine kinase and toxic epidermal necrolysis-like reaction. Therefore, the colchicine during pregnancy, there is transplacental crossing of colchicine, no increased risk of fetal abnormality in colchicine-treated pregnant patients. Please go on. Use colchicine should be continued in pregnancy. Therefore, what about the unresponsive patients to colchicine? This is not common. This was associated with inadequate colchicine concentration in mononuclear cells. The supplementation of oral colchicine with weekly intravenous colchicine 1 milligram resulted in 50% reduction in attack frequency. Please, intravenous colchicine should not be administered to patients taking oral colchicine because of severe fatal toxicity which can occur. Please, these agents should be avoided. Cisplatin worsens symptoms of FMF. Cyclosporin inhibits hepatic excretion of colchicine, leading to colchicine toxicity. And at the end, take home this message. FMF is a clinical disease. It is very important to hear your patients. It is very important to know the diagnosis from the talk to your patients. It is supported by genetic study. Should not overdiagnose. Many patients I find overdiagnosis. Or please don't miss the diagnosis. And that is, if you don't hear well to your patient, you miss the diagnosis. For prevention of development and progression of amyloidosis. And at the end, I tell you, thank you very much. And I hope don't miss and do not overdiagnose the FMF. Thank you.